Good evening, everyone. I am Dr. Satyabrata, MDDM clinical pharmacologist, and today I am going to discuss on clinical pharmacology of itraconazole. We all know that itraconazole is in the triazole group and it lacks the corticosteroid suppression. Itraconazole is the drug of choice in case of B. dermatitis, H. capsulatum, P. brasiliensis, Coccidioides immitis, and it can also be used in case of aspergillosis and onychomycosis. Then coming to clinical pharmacological considerations. It is available as tablet, capsule, oral solution. Capsule better absorbed in fed state, but oral solution better absorbed in fasting state. Its peak plasma concentration of oral solution more than 150% of those obtained with the capsule. Both a substrate for and potent inhibitor of CYP3A4, 5, CY3P3, CYP3A7, and its active metabolite is hydroxyitraconazole. It is metabolized in the liver and 99% plasma protein bound. It neither appears in urine or CSF. Its T-half is 30 to 40 hours. Steady state not reached for 4 days for itraconazole and 7 days for hydroxyitraconazole. Loading doses needed to treat deep mycosis. Severe liver disease increase plasma concentration of itraconazole. Azotemia and hemodialysis have no effect. This is the table showing itraconazole, Cmax, Tmax, AUC from 0 to infinite, T-half in the fed state and fasted state, and it also shows the Cmax, Tmax, AUC 0 to infinite and T-half of hydroxyitraconazole in the fed state and fasted state. Coming to microbiology, itraconazole inhibits the cytochrome P450 dependent synthesis of ergosterol. Itraconazole exhibits in vitro activity against blastomyces, dermatitis, histoplasma capsulatum, histoplasma dobosci, Aspergillus flavus, Aspergillus fumigatus, Candida albicans, and Cryptococcus neoformans. Itraconazole also exhibits varying in vitro activity against Porothrix senki, Tryptophyton species, Candida krusei, and other Candida species. Candida krusei, Candida glabrata, and Candida tropicalis are generally the least susceptible Candida species, and itraconazole is not active against zygomycetes. Coming to the contraindications, itraconazole is contraindicated in case of congestive heart failure, pregnancy, hypersensitivity, severe renal impairment, hepatic impairment. Coming to drug interactions, concomitant administration of itraconazole capsules or oral solution and certain drugs metabolized by cytochrome P450 3A4 isoenzyme system CYP3A4 increased plasma concentrations of those drugs serious and life-threatening adverse events. Cisapride, oral midazolam, nisoldipine, felodipine, pimozide, quinidine, dofetilide, triazolam, methadone, and levacetyl-methadol contraindicated. HMG-CoA reductase inhibitors metabolized by CYP3A4 like lovastatin and simvastatin contraindicated with itraconazole. Ergot alkaloids metabolized by CYP3A4 such as dihydroergotamine, ergotamine, and methylergometrin are contraindicated with itraconazole. Antiarrhythmics like QT prolongation with itraconazole, that's why contraindicated. Anticonvulsants, reduced plasma concentration of itraconazole were reported when itraconazole was administered concomitantly with phenytoin. Antimycobacterials, plasma concentration of azole antifungal agents and their metabolites including itraconazole and hydroxyitraconazole were significantly decreased when these agents were given concomitantly with rifabutin or rifampin. Antineoplastics, itraconazole inhibits the metabolism of busulfan, docetaxel, and vinca alkaloids. Antipsychotics, pimozide is known to prolong the QT interval and is partially metabolized by CYP3A4. Benzodiazepines, concomitant administration of itraconazole and alprazolam, diazepam, oral midazolam, or triazolam increase plasma concentration of these benzodiazepines, prolong hypnotic and sedative effects. The calcium channel blockers. Edema has been reported in patients concomitantly receiving itraconazole and dihydropyridine calcium channel blockers. Appropriate dosage adjustment may be necessary. Gastric acid suppressors oblique neutralizers. It reduced plasma concentration of itraconazole were reported when itraconazole capsules were administered concomitantly with H2 receptor antagonists. Gastrointestinal motility agents. Co-administration of itraconazole with cisapride elevate plasma cisapride concentrations. Serious cardiovascular events can occur. HMG-CoA reductase inhibitors. Human pharmacokinetic data suggests that itraconazole inhibits the metabolism of atorvastatin, serivastatin, lovastatin, and simvastatin, leads to skeletal muscle toxicity including rhabdomyolysis. Immunosuppressants. Concomitant administration of itraconazole and cyclosporine or tacrolimus increase plasma concentrations of these immunosuppressants, and concomitant administration of itraconazole and sirolimus increase plasma concentrations of sirolimus. Macrolide antibiotics. Erythromycin and clarithromycin are known inhibitors of CYP3A4 increase plasma concentrations of itraconazole. Oral hypoglycemic agents. Severe hypoglycemia has been reported in patients concomitantly receiving itraconazole and oral hypoglycemic agents, but glucose concentrations should be carefully monitored. Protease inhibitors. Concomitant administration of itraconazole and protease inhibitors metabolized by CYP3A4 such as indinavir, ritonavir, and saquinavir increase plasma concentration protease inhibitors. In addition, concomitant administration of itraconazole and indinavir and ritonavir but not saquinavir increase plasma concentration of itraconazole. Co-administration of methadone or levacetyl methadol with itraconazole serious cardiovascular events. Elevated concentrations of ergot alkaloids can cause ergotism. Itraconazole inhibits the metabolism of certain glucocorticoids such as budesonide, dexamethasone, fluticasone, and methylprednisolone. Itraconazole enhances the anticoagulant effect of coumarin-like drugs such as warfarin. Geriatric use. Transient or permanent hearing loss has been reported in elderly patients receiving treatment with itraconazole. Concurrent administration of quinidine, which is contraindicated. HIV infected patients. Due to hypochlorhydria in HIV infected individuals, the absorption of itraconazole may be decreased. Coming to adverse reactions of itraconazole, it can lead to nausea, vomiting, diarrhea, abdominal pain, anorexia, constipation, dyspepsia, gastritis, gingivitis, angioedema, alopecia, toxic epidermal necrolysis, that is TEN, hypertension, hypokalemia, urticaria, adrenal insufficiency, gynecomastia, hepatitis, impotence, myalgia, etc. Coming to the special precaution. Patient with risk factors for CHF, congestive heart failure, renal and hepatic impairment, pregnancy and lactation. Monitor LFT, RFT, liver function test, renal function test, and signs, symptoms of congestive heart failure during itraconazole use. Neuropathy, hearing loss. Capsules should be administered after a full meal. Studies conducted under fasted conditions demonstrated that administration with 8 ounces of a cola beverage resulted in increased absorption of itraconazole in AIDS patients with relative or absolute achlorhydria. Coming to the therapeutic uses, treatment of blastomycosis and histoplasmosis. The recommended dose is 200 mg once daily, 2 capsules. If there is no obvious improvement or there is evidence of progressive fungal disease, the dose should be increased in 100 mg increments to a maximum of 400 mg daily. Treatment of aspergillosis. A daily dose of 200 to 400 mg is recommended. Treatment in life threatening situations. In life threatening situations, a loading dose should be used. Loading dose of 200 mg, 2 capsules 3 times daily, 600 mg per day be given for the first 3 days of treatment. Treatment should be continued for a minimum of 3 months and until clinical parameters, laboratory tests indicate that the active fungal infection has subsided. Treatment of onychomycosis. Toenails with or without fingernail involvement, the recommended dose is 200 mg, 2 capsules once daily for 12 consecutive weeks. Treatment of onychomycosis, fingernails only, then the recommended dosing regimen is 2 treatment pulses, each consisting of 200 mg, 2 capsules BID 400 mg per day for 1 week. The pulses are separated by a 3-week period without itraconazole. Used in patients with renal impairment as well as hepatic impairment. Limited data are available. Caution should be exercised. These are the references. You can go through the references for further learning, further improvement of your knowledge. Thank you very much. Jai Jagannath.